This is going to be topic 28.2, abdominal pain.
And key concepts. Upon completion of this chapter, you will understand the realization that complaints of abdominal pain are common and can be due to benign or life-threatening situations, the importance of patient description of the pain and its location in identifying the likely organ involved, why paramedics should consider abdominal pain in women of childbearing age and ectopic pregnancy until proven otherwise, the need to direct interventions towards identifying life threats and promoting patient comfort, including the relief of pain and nausea. Chief concern. Pain in the abdomen, it can be somewhat ambiguous, arises from many organs within the abdominal cavity. Referred pain is felt in one area even though actually pathology is in another area. So this is why whenever we have chest pain, we can get referred pain up into the jaw and down into the arm. Abdominal contents and quadrants. Point tenderness, pain associated with a specific area. It may be related to a specific organ. Diagnosis on this can be very broad if we're having point tenderness in one area. Core organs lie underneath floating or false ribs under the protection of bony ribs, and they actually lie within either the abdominal cavity or within the retroperitoneal cavity. Abdomen is divided into 4 quadrants, even though some prefer the 9-quadrant system, and they prefer it because it's more precise and tends to focus on specific organs. We're fixing to look at 2 tables, or 2 figures. Figure 21, which is organs and structures within the abdominal quadrant, and then after it we'll look at 22, 9-quadrant abdominal system. So this is the abdomen divided into 4 quadrants. And that tends to leave a lot of organs in this one area. So that's why most people, or some people, like the actual 9-quadrant. Liver's up here, some of the stomach and the intestines in the right upper quadrant. Pancreas, gallbladder are also up here, left quadrant. Spleen, intestines again, and more of the stomach. Right lower quadrant being our appendix. Left lower quadrant, just mostly intestine. Rectal area. And this is the 9-quadrant. So whenever you're looking at it, if you're in the right hypochondric region and you had pain here, this would isolate it down to either the gallbladder, the liver, maybe common bile duct, but it would isolate it a little bit more. Epigastric, umbilical region, hypogastric region. Right lumbar, primarily intestine, right iliac region with the hypogastric region, might possibly be the appendix, left hypochondriac, spleen, very tip of the liver and stomach, left lumbar, which is mostly intestine, left iliac region, which is mostly lower intestine as well. Differential diagnosis, abdominal pain. A wide variety of conditions primarily manifest in the quadrants, right upper quadrant, upper left quadrant, lower right quadrant, and lower left quadrant. Generalized abdominal pain. Area of pain cannot be specifically identified. Pain is diffuse all over the abdomen. Gastroenteritis is one of the things that can actually cause this. Acute inflammation of the entire gastrointestinal tract, often due to a virus or bacterial infection. Peritonitis, inflammation of the peritoneal cavity, and this is what all of the abdominal organs reside in, often results in a rupture of a hollow abdominal organ, and this would be because the fecal matter spilled out into the peritoneal cavity and caused an infection. Patient probably would be septic as well, give or take. Depends on how acutely this was. If it's been over the last couple of days, it might give enough time for an infection to set up in the peritoneal area. If it would happen that day, within the last hour or two, might be able to get ahead of that. Includes, and this is upper quadrant abdominal pain, this includes the hepatomegaly or enlarged liver. It can cause upper right abdominal pain, cirrhosis, inflammation of the liver, several types including alcoholic hepatitis, drug toxin-induced hepatitis, and viral hepatitis. Hepatic abscess can also cause hepatomegaly. Can occur if the extrahepatic biliary system is obstructed or outside the liver biliary system. Cholecystitis results from a stone stuck in the gallbladder, leading to irritation, inflammation, and infection. Choleolythis, which are a type of gallstones or cholesterol gallstones. Biliary colic, right upper quadrant pain. Jaundice, and this can occur, this is yellowing of the skin and even the sclera. The sclera would be yellowing of the eyes or the whites of the eyes. Cholangitis, inflammation of the bile duct. Pancreatitis, inflammation of the pancreas. Common cause on this is going to be gallstones. Other factors, we can get blunt trauma infections, congenital abnormalities, tumors, drugs, and other miscellaneous causes. Pancreatic cancer often is without symptoms or asymptomatic until it reaches an advanced stage, and it has a poor prognosis whenever they tell you you have pancreatic cancer. It's generally widespread by the time that they find it. Gastritis, inflammation of the lining of the stomach, caused by bacterial infections or NSAIDs, non-steroidal anti-inflammatories, aspirin, Motrin, things like that. Alcohol use, steroids, radiation, and a host of other causes. Peptic ulcer disease, caused by an erosion of the tissue of the stomach or duodenum, more commonly the duodenum. Risk factors on this are infection, medication, stress, excessive secretions of gastric acid, Zollinger-Ellison syndrome, disorders of gastrin production, which in turn produces excessive stomach acid. Increased risk for peptic ulcer disease if this is occurring. A perforated peptic ulcer. Peptic ulcer perforates the intestinal wall, allowing free air to enter the abdominal cavity, as well as spillage of the stomach acids and intestinal content into the abdominal cavity. This generally will result in peritonitis or inflammation of the peritoneal lining. Associated non-abdominal source of upper right quadrant pain, supraphrenic abscess, collection of pus just below the diaphragm, can cause right upper quadrant pain. Right lower lobe pneumonia can also kind of throw a monkey wrench into our ball of wax here. Lower quadrant abdominal pain includes a possible ectopic pregnancy. Can be a life-threatening emergency. They're assumed pregnant, possibly with an ectopic pregnancy. Any female of childbearing years with lower abdominal quadrant pain might possibly have an ectopic pregnancy until proven otherwise. Intestinal obstruction occurs most commonly in the lower intestine. Mechanical obstruction or non-mechanical obstruction. We also have a paralytic ileus. Peristalsis does not move the fecal material through the intestine. It becomes inflamed and starts hurting. Small bowel obstructions can potentially be life-threatening. Can occur from a number of pathological or intergenic causes. Third space fluid shifting. Pressures within the lumen of the small bowel increase. Hydrostatic pressure increases. Massive amounts of fluid shift into the interstitial space. Intussusception is a blockage of the small bowel. We also have hernia, weakness or an opening in the muscular structure of the abdominal wall. There are several different types of hernias. There are inguinal, most common especially in men, femoral, ventral, and umbilical. Large bowel obstruction stops passage of fecal material. Colorectal cancer usually starts as a small mushroom-appearing polyp, changes over time and becomes cancerous. Tenesmus, feeling of incomplete bowel or emptying, can occur as one of the symptoms. And then fecal impaction occurs when the bowel movement stops and fecal material backs up in the colon. This is lower quadrant abdominal pain continued. Volvus, where the colon twists upon itself. Hirschsprung's disease, most common cause of lower intestinal obstruction in the newborn's life. Genetic mutation that causes a congenital absence of ganglial nerves in the bowel walls, including the rectum. Megacolon, the colon expands. Ogilvie syndrome, acute pseudo-obstruction of the colon. Non-obstructive lower abdominal pain, things like ischemic bowel syndrome, Arterial occlusion secondary to a rupture of an atherosclerotic plaque cuts off blood supply to a section of bowel. Generally occurs in the superior mesenteric artery. Appendicitis, inflammation of the veriform appendix or appendix. Surgical emergency. If left untreated, the appendix could rupture, causing peritonitis and other complications. There's some assessment points on this, McBurney's point being one of them. Location 2/3 of the distance on an imaginary line from the umbilicus to the anterior superior iliac crest toward the hip. Maybe the point of tenderness for this location if they're having an appendicitis. Robsing sign, pain in the right lower quadrant when the left lower quadrant is palpated. Diverticulitis comes to mind as well. Diverticula become infected, and a diverticuli is like an outcropping of the large intestine or pocket, such as by fecal material that blocks the opening of the diverticulum. And I remember a diverticulum is an outpocketing of large intestine. Rectal abscess. Perirectal abscess occurs when an infection sets into the anal glands and that drain actual mucus into the anal crypts. So it would just be an inflammation or an infection of that area. History. Consider primary focus on the patient's pain. What time did the symptoms onset? The standard OPQRST mnemonic. If there's any type of referred pain and anything that makes it better or worse or provokes it. And when was their last bowel movement? As far as examination, focus on the abdomen. Swelling and pain location, bowel sounds, palpation, peritonitis assessment. Abdomen will feel warm to the touch. Cholecystitis assessment would be Murphy sign. Paramedic places his hand over the right upper quadrant. Murphy sign is for a gallbladder. At the midclavicular line and asks the patient to exhale and then inhale. As the patient inhales, the paramedic applies downward pressure. If the patient stops inhaling due to pain, then the patient has a positive Murphy sign. Appendicitis assessment is an obturator sign. Patient lies supine with the right knee bent and the right hip flexed at 90 degrees. Paramedic then takes the right ankle and gently rotates the hip away from the body. If the obturator is inflamed, then the patient will experience pain, and this is positive finding for a possible appendicitis. On assessment, viscera comes from abdominal organs. Referred pain, visceral pain, is often referred to as other parts of the patient's body. Somatic comes from the parietal peritoneum. Now, whenever we look at this, we can get all kinds, like, look at this up here. This is liver or colic pain, right upper shoulder, biliary colic, cholecystitis, gallbladder attack, or pancreatic, renal, maybe diffuse, pancreatic renal colic in the back pain, penetrating duodenal ulcers, cholecystitis. So we can have any type of abdominal referring to pain depending on how their neural tissue is piped. These are the most common ones seen, and this is figure 23, referred pain sites in your book. This is table 27, time of onset of abdominal pathology. So sudden onset stuff. Acute MI, mesenteric infarction, ovarian torsion, perfed ulcer, PE, pulmonary embolism, ruptured abdominal aortic aneurysm or AAA, ruptured ectopic pregnancy, ruptured ovarian cyst. So all of these are very sudden. They just happen, bam. Very rapid. Now, acute pancreatitis. So this progressively got worse, at least over some hour periods. Biliary colic, diverticulitis, intussusception, renal and ureteral colic, strangulated hernia, volvus. So these things are they started at this time and the symptoms slowly have progressed. And then things like gradual, appendicitis, chronic pancreatitis, urinary tract infection or cystitis, inflammatory bowel disease, mesenteric lymphadenitis, salpingitis or tubo-ovarian abscesses, and then prostatitis. Now these have even a slower upswing, if you will. These occurred gradually, but they're progressively getting worse. Treatment considerations: keep the patient nothing by mouth or NPO. Large bore venous access capable of transfusing blood and correcting hypovolemia. Drawing blood samples, clotting times, and hemocrit for use preoperatively. Nausea and vomiting treatment, any kind of antiemetic, things like zofran or possibly Phenergan. Patient treatment as far as analgesia, fentanyl, some kind of pain reliever. On evaluation on an acute abdomen, sudden decompensation with abdominal pain may indicate a surgical emergency. Etiology is varied. Beyond the patient or the paramedic skill level, we're going to need ultrasound and something to scan inside there to actually figure out what might be wrong in the abdomen. Table 20.8 is acute abdomen. Now, any of these acute appendicitis, along with our physical assessment, a CBC, and a CAT scan is always awesome. Perforated ulcer, looking for free air up underneath the diaphragm. If they need an angiogram for their atherosclerotic thrombus, hypovolemia secondary to diarrhea and vomiting, thromboembolism, CAT scan is always the best way to rule that out, the D-dimer. Ectopic pregnancy. They may actually CAT scan on the ectopic pregnancy, or they might actually do an ultrasound, something like that. So they always look for other things besides just the physical findings, because they can be very broad when looking at the abdomen. Special case of the ectopic pregnancy. Not dismissed as a cause of severe abdominal pain. Any woman that is capable of childbearing with lower abdominal pain, assume they are pregnant and at risk for ectopic pregnancy until proven otherwise. Disposition, we should treat this like an acute abdomen. Consider a surgical emergency. Transport immediately to a capable surgical center. En route, notify the hospital of impending arrival and help prepare the patient for surgery. In conclusion, chief concern of abdominal pain, a wide array of differential diagnosis often require additional investigation and additional tests. Through history can narrow down the diagnosis if you can isolate down a specific history. Paramedic must be vigilant for life-threatening causes of abdominal pain.
If you have any questions concerning this topic, feel free to contact me. My name is Roy Smith. Smith Art, Samaritan EMS, OK.com, or 405-492-8243. Thank you.